right? In 1 month. So what is the problem with MBS is the principle. So currently the principle of MBS, traditionally, we have a restrictive mechanism. We also have malabsorptive mechanism. Don't worry, I will going to describe about this later. And this is a traditional pathophysiology on what we think, right? What the surgeons think for the past decades. But now the modern with a newer perspective, actually bariatric surgery, metabolic and bariatric surgery is a hormonal surgery. We have a foregut theory, we have a hindgut theory. All right. Okay. So what are they? Restrictive. Let's say restrictive. It's very easy. I just I put a band, all right, over the stomach, all right. So the stomach will get distended. Once the stomach get distended, you will have reduced hunger, right? Okay, you reduce more hunger, but there's a big stomach below that. So this is a restrictive. You try to restrict the food intake of the patient. So what you do is this is a picture of an adjustable band, but we don't look at that. We are looking at the procedure later on. What I want you to focus on now is the restrictive mechanism, right? So what you can do is restrictive. You always go to the stomach where you want to reduce the stomach, right? Like for this diagram, this is a RYGB, the Roux-en-Y gastric bypass, and you see the gastric pouch is only very small. Okay, that is so small that the patient unable to eat, right? So that is a restrictive point of view. And on the other hand, you have a malabsorptive point of view. Malabsorptive, what does it mean? It means we bypass the intestine. So if we bypass the intestine, you look esophagus, the patient eat cat. Oh, now can eat KFC already, right? Boycott already, right? Mary Brown lah, homegrown, all right. So you eat many brown, or okay lah. Now it's very sensitive. You can take fried chicken, all right. So you take whatever fried chicken, esophagus, go into the pouch, and you have already bypassed, right, the intestine, right. So this is the malabsorptive point of view. Okay. So the food, how does the human body digest food? And in turn eventually will cause a absorption. You need bowel, right? You need bowel because you need pepsin, you need renin, right? You need lipase, you need amylase. Of course, amylase from saliva, but the amylase from pancreas is more important, right? So you need all these enzymes to digest the food component in order for your body to get absorbed. So what you do is you put this long. This is the non-scale diagram. Usually, depending on the patient, on the surgeon, some surgeon they can put 75 centimeter, but I think it's rather very short. Or some surgeon they put 100 or 150, right? And for this, they put maybe 75 or also 100 to 150. So all in all, it might be 150 to 300, right? So we must know the normal population, the total bowel length. The total bowel length is how much? Now that is the problem when we do a RIGB, because RIGB we only look at above. The problem is the technicality of counting the bowel. So most of the surgeons, they don't count the total bowel length. So that is a thing, right? Um, I have a study and unpublished. I can tell you for at least for Taiwanese population is about 300 to 1,000. That is the population of 800 cases, and the total bowel length, because we routinely calculate our bowel length. So that is the range. You see, the range is so varied. So that is the problem. That is why I advocate to calculate the total bowel length for all the patients. right? But okay, so enough said. The problem with that is, let's say this patient is 600, so you already bypass, let's say 300, right? So you only have 300 intestine to digest and absorb. So that is what we call malabsorptive, right? Let's go to the anatomy of the gastric bypass. I think this is actually, it won't come out in exam anyway. This topic won't come out in exam. Okay, but at least for you budding surgeon, right? You are all are new budding surgeons. You are going to become my colleague maybe in the 5 to 10 years time. All right. So I shall tell you the anatomy of a gastric bypass, which is actually because gastric bypass is the gold standard. And from the gastric pouch, right, towards the bifurcation or the anastomosis, or we call it a common channel, right? This is what we call alimentary or lulim, right? And the one from the duodenum towards the common channel, which is what we call a biliopancreatic, because bowel, biliopancreatic limb, right? Okay, this another limb is very, very important, this limb. And of course, the common channel, right? So you have, if you are going to do a gastric bypass, which is a RYGP, right? You will have a blue limb or alimentary limb. You will have a BPL, a biliopancreatic limb, and also a common channel, right? So, and the most important is the blue limb and plus the common channel, you become the total alimentary limb, or we call it TAL, because this is the limb that is functional. All right. Okay. So these are the terms to use for the anatomy. And mind you, if you are going to, there are a lot of ways to do a RIGB, but here I just want to show you the RIGB will cause internal herniation, and those are the defects. If you are a surgeon, you have to close this defect. A is the transverse colon defect, B is a Patterson, and C is a jejunal defect. All right. So is it important for your exam? No. Will it come out from your exam? No. Okay. But later on, when you are going to be a bariatric surgeon, this is very important because you must close all these defects, right? Okay. So we go to the more interesting perspective, which is the gut hormones. Little that we know that actually gut produces at least 5 gut hormones. And these hormones are actually being extensively researched and studied. And at least we know a few of them. The foregut means the from the ligament of traits. All right. So we are not saying that these hormones are only being secreted in the foregut, but it's more dominant in the foregut. All right. So there is a difference, right? So that means the small intestine actually they would have a little amount in which actually we are still not so good at that because it's not have really been even though it's been extensively researched, but we don't have the answer yet. But one thing is the most popular hormone is the ghrelin. The ghrelin, initially we thought it was only in the fundus, but actually it's in the whole stomach. The whole stomach is secreting ghrelin. And this ghrelin is the one that causes hunger. Then cause hunger sensation. All right, that is ghrelin, right? So how does ghrelin being secreted? Is when your stomach is collapsed. When your stomach is collapsed, your stomach will secrete ghrelin and ask and signal your brain to go and eat. All right. And there was also PYY and also CCK. Your favorite CCK. They call it the cholecystokinin, right? And also high gut. So because you guys, most of you are students here, I just want to tell you ghrelin for gut and high gut is GLP-1. All right, glucagon-like peptide 1, type 1. And GLP-1 has been a very big money-making material, I mean a factor, right? Okay, because this can come in the injection form, can come in the oral form. And this GLP-1 most are being secreted in the distal ileum. And GLP-1 will increase your satiety. So how does GLP-1 be secreted? It's just that the food, the kind, right, has been bypassed into the distal ileum, and that one will be secreted. And the small intestine, the distal ileum, will tell your brain that okay, you eat enough. Okay, that's satiety. All right. So you must remember hunger, satiety, and satiation. They are three different things. All right. Okay. So and also GIP. GIP is another new thing, another new key. Right. So I blah 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 so much. Okay. The one thing is what is foregut theory. If we look at the perspective of a hormonal surgery, all right, sleep. Sleep gastrectomy, it can be, if you look at the perspective of restrictive, yes, it's a restrictive procedure as well, because the patient can only eat so much, so and so much. It depending on the surgeons. Some surgeon will take 50 meals, some surgeon will take 100 meals, 150 meals. But one thing, if you look at the foregut theory, just now I said foregut is ghrelin, right? All right. Or what is the exact difference we discuss later on. Okay. So the gastric sleeve, we taking a bit 70% of the stomach out. That means the 70% of the ghrelin secreting, or we call it L cells, all right, have been taken out. So this will cause less hunger to the patient. All right. So if you look at restrictive, some surgeon will just say, "Oh no no no, you must you shouldn't too much. It's too restricted." All right. But if you look at the hormonal perspective, you would like to take as much of the stomach out as possible. If you look at the RYGB, there is a remnant stomach there, right? Remember the remnant stomach there. That's why RYGB it also cause a weight regain. That is another one problem with weight regain, right? Okay, high gut. High gut is the GLP-1. So this duodenal switch. Duodenal switch is one of the, the ceiling, okay, the most difficult bariatric procedure, right? There is a ceiling already. So you can do a duodenal switch in which you must look at the difference between duodenal switch and RYGB. RYGB, you already take out the pylorus, but duodenal switch is at the duodenum. It's a duodenal jejunal anastomosis. So the duodenum is you still have the pylorus, right? That makes a lot of difference. Pylorus is your friend, right? But one thing is they will calculate how much is the intestine, and usually depending on the surgeon, it can have 200 up to 350, right? So it actually depends on patient, of the surgeon, and also not really depend on surgeon, or also the patient as well. All right. Some patients will need 250, some patient will need 300 of the common channel. All right. So if you have a lesser common channel, all right. So if you have a more GLP will be increased because more food will get into the distal ileum. All right. Understand this? Huh? So this will, it will increase the GLP-1. All right. So we come to issues. This one. What is the difference between satiety, satiation, and also hunger? All right, hunger. We talk about hunger first. You guys ever feel hangry? All right, when you feel hungry, you hangry, right? You angry and hungry, so hangry, right? So if you feel hungry, right, that is a sensation of you need to eat something, right? That is hunger. All right. Satiety, you already feel you don't feel anything, you don't want to eat anymore. That is satiety. All right. Satiation is you feel full, right? Satiation is like, wow, I really full already. I think if you go to buffet, right? You guys are students, right? You guys like to go to buffet, right? So you guys go to buffet and until station, all right? Okay. even though you already have satiety, but you eat until you have satiation, right? So that is the difference. And this is actually quite scientific term. If you want to look at a scientific term, there is a very long definition. You can look up actually. Or after this, you can ask me again. Then I will tell you the exact term. But that the concept is there. So there are three different things: hunger, satiation, and satiety. I hope this one answer your question. All right. Okay. Feel full after eating. Really cannot muscle already. Very good, very good. No, satiety is you don't feel like to eat, not full. It is not feeling full. Satiety is you don't feel you like to eat. Right? Hunger, you want to eat. Right? So you are like a predator. You want to eat something. All right. I don't feel like eating. Yeah. Don't feel like eating. Okay. Later you saw the depression. Later on you can find the real definition because the wordings are very specific. Okay, so this is what we do in China Medical and the types of MBS intervention, right? So what are the types of intervention? The gold standard currently, according to IFSO, is still RIGB, the Roux and White gastric bypass. So this is something quite traditional and gold standard. Why is it gold standard? Right? Gold standard doesn't mean that it is the best. All right. Gold standard means that everybody can do it. And this is actually a procedure which can be used as a rescue procedure. Like something wrong with your sleeve, and then you can revert back to RIGB. Something wrong with your OAGB, and then you can revert back to RIGB. But RIGB, personally, I don't really advocate it. Right? Okay, so for surgical and non-surgical, so for surgical, we have a leg adjustable gastric band. And don't worry, all these procedures I'm going to describe one by one. You have 1 hour with me, right? Okay. And you have BPD, which is a biliary pancreatic diversion. You have we call it mini gastric bypass or one anastomosis gastric bypass. We have sleeve. This is the most popular procedure nowadays, right? We have sleeve plus. We have sleeve plus means we sleeve and then we plus another procedure, sleeve plus. In sleeve plus, we have sedis, right? We have sleeve and duodenal switch, right? And also PJB. PJB is a proximal jejunal bypass. And we also have a non-surgical intervention, all right? We have an intragastric balloon. We have endoscopic sleeve gastroplasty. We also have a post, right? So post 2.0, there's a post 1.0, there's a post 2.0. For me, I can do all this, but the problem is I don't advocate as well because you know why? All these are still at the restrictive malabsorptive theory, right? They are still thinking at the restrictive there. They are not thinking of hormonal. If you think about it, they have nothing to do with the hormonal. They don't change any hormones, the gut hormones, right? For non-surgical. That's why, is it good? Okay, we describe later on, right? So this is a laparoscopic RIGB. All right, this is gold standard. All right, that's why I said it's gold standard. The principle is that it's a restrictive and also a malabsorptive procedure. So this RIGP has been popular for maybe 40 to 50 years, right? So the theory is that this is the alimentary limb, right? The longer is your BPL, the longer is your biliopancreatic limb, the more malabsorption you will get. All right. The longer is your alimentary limb or low limb, the less reflux the patient will get. Okay. So that is another theory you can play around. That's why you can play around with the limbs, right? The advantage, yes, this is one of the best, right? 70 to 80% of excess weight loss. You must understand what is excess weight loss. Excess weight loss is we calculate the target weight at 22.5 BMI, right? And the rest of the weight is actually excess weight loss. So excess weight loss in 12 months usually is 70 to 80%. And this is one of the rescue procedure to be done for the patient we have reflux. If you are not doing MBS, reflux is always a problem, right? So it can also be used as a revisional procedure, right? You can revision other procedure and you can convert it to become RIGB, right? What are the disadvantage you can see, even though it's a gold standard, later uh you will note that there is actually more disadvantage doing the RIGB. Okay, the most important disadvantage is malnutrition. The malnutrition, yes, protein. My favorite protein is always cannot be absorbed. And one thing is also because the patient doesn't, we didn't address the hunger. Why? Because you see, they are still grilling. The stomach is still there. It's not been taken out. It's only a restrictive part, right? Okay. And also, usually the one who do RIGB, they don't calculate the total bowel length because it's actually technically is quite difficult to do. All right, it's fair enough, acceptable. But one thing is because if you don't calculate the total bowel length, and you do know the total elementary limit is as such. So you do not know your GLP-1 how much will be increased. And also another one is the vitamins, right? Why? You can see that the difference between the SEDIS, right? Or PJB. And to this is, you see, it didn't go across the pylorus. The pylorus is very, very important, right? The antrum is the one that secrete the intrinsic factor. Intrinsic factor, just hopefully you guys are good in physiology. Intrinsic factor is very good, is very, very important for vitamin B12, namely, right? And also some iron, right? Absorption. That's why they also have anemia. So the anemia, it can, we do not really know why the patient with anemia, but usually they say iron deficiency. But is it iron deficiency? Hemoglobin is not only heme, they also globin, right? So globin is actually protein. Can it be because of the amino acid is not enough? The adoption of the amino acid, right? Why? Why adoption of the amino acid not enough? Right? Because there's no pylorus, right? Okay. So, and you look at the stomach, the acid secretion is much less, right? The problem with RIGB and the problem with most of the MBF is weight regain. Weight regain 3 to 5 years. After 3 to 5 years, there studies have been shown weight regain is also in RIGB. That is the problem. We want a permanent solution. We don't want something temporary, right? Stomach ulcers. Stomach ulcers is very notorious in RIGB. Be up to 10 to 20%. 20% is a lot. 5 RIGB, one stomach ulcer. Stomach ulcer, you will have a upper GI bleed, right? And one more thing is the internal herniation. Remember the defects, right? They can go into the defect. It's not, if the defects are not being, it's not to say the surgeon, maybe some surgeon they don't close it. Some surgeon they close it, but one thing is, even though they close it, when the patient lost weight, right? And all this suture become loose, and that one will become the potential defect and become the internal herniation. And the most notorious one is dumping syndrome, right? Dumping, you have a early and late, right? So I hope today I haven't saturate your young minds here. Okay, just to know, dumping syndrome is a problem in the RIGB. Okay, so intragastric balloon, this thing have been quite commercial. I think you guys in TikTok, in Instagram, even in Facebook, all right, you will see there's a company who dance together with the balloon, all right. And one thing is, this balloon, if you think of it, what mechanism is that? It's only restrictive, right? It has nothing to do with hormones. But one thing is, it will have excess weight loss. of a 10 to 20% in 4 months only, or as long as the balloon is there. 4 months because one of the company then 4 months. Once the balloon is out, and then the weight regain. But the advantage is it's a clinic procedure, right? Can it be used as a bridging procedure? Okay. That one I put a question mark there, right? And one thing is it must couple with a very good team. What team I am talking about is a nutrition team. The patient, you must revert like what the Jane today here, right? She will try very hard to tell you eat protein, all right, don't eat carbs, all right. It's very difficult to do, all right. And the disadvantage, of course, the weight regain. Then the main problem with this procedure is the vomiting. The vomiting at the first week. Why? Because if the patient has not been acclimatized to less food and with a balloon inside, then what they do? They eat and vomit because there's not enough space in the stomach. Vomit is not a problem, actually. But what is the problem? Aspiration. You vomit and you aspirate. Especially, all these patients, they would eat and lie down. Right? Once you eat and lie down, you vomit, you aspirate. Right? And there are some rare occasion, bowel obstruction due to rupture balloon. It can, because the balloon rupture, can we imagine a balloon rupture is actually some sort like a PTFE, right? And this thing will go into the small intestine and get blocked. It become an intraluminal obstruction, right? Then cause IO. And then if not being careful, the clinician who put in, it might cause the esophageal perforation, even though out of thousands, there's one or two, you just need one esophageal perforation, right? The patient will die, right? And one thing is the ESG. ESG has been here maybe for 20 years, but the principle is still is a restrictive because it's reduced the gastric space and it will leave a portion of a fundus that will increase the patient, right? So the excess weight loss for this is quite promising, 40 to 50% in 12 months, and it's a relatively fast procedure, and it can be done endoscopically, or they promoted it as a incisionless because you really have no scar. You all everything do an endoscopically. Okay, what is the disadvantage? Disadvantage is it needs a special endoscopic suturing device, and this device is relatively expensive, right? And then the weight regain. But the problem with weight regain, some advocate, they will say we can re-ESG. And if you come to a surgeon like me, I will say revision. I will revise. Why? Because this thing is not hormonal. This is only a restrictive point of view. It's not hormonal. So that is the problem. Okay, post is a primary obesity surgery endoluminal post. There is post 1 and post 2. Now it's a post 2.0. Don't worry about post 1. Okay, post 1 is not so good. That's why they have post 2, right? It's like BROF 1, BROF 2. All right. So what is the difference? ESG, they suture the antrum up to the mid body. Post, they suture the fundus and the mid body. So that is the difference. But post, the excess weight loss is not so good, right? It's only 25 to 40% in 12 months. But the learning curve is shorter, and the machine is cheaper. Okay. All right. And the disadvantage is, of course, weight regain. Why all these procedures have weight regain? Because they are not hormonal perspective. And very rare, I would not say very rare, it's actually rare. All right. We have a hepatic access. Right. So why you have a hepatic access? You are actually going through the splenic circulation, and you contaminate because remember the lumen of the bowel is not sterile, right? Okay, so we go to surgical intervention, the LAGB. LAGB was the popular guy, all right? It was a very, very popular uh, for maybe 20 years ago, 10 to 20 years ago, maybe. But now it's almost obsolete because there's a lot of problem. The problem, I tell you, right? Principle is just restrictive, right? And the advantage is very simple, it's very fast. Learning curve is very fast, right? It's very simple to do. And the one thing you can adjust, the patient can just adjust. It's like like a chemo pot. It's exactly a chemo pot, right? And you can just put the pot under the skin and then you can adjust the restriction. The even disadvantage is it causes a lot of refluxes. And the worst is it causes gastric erosion. And erosions can cause perforation. And the problem with that is also most of them have weight regain after 2 to 3 years. And this mostly will need a revision. And I can tell you, you do not like to do a revision on the LAGB. There's too much addition, too much of fibrosis. You will cry, okay? So that's why it's almost obsolete now. Okay, there's a new kid on the block. This is a OAGB, or we call it mini gastric bypass. Right? It's like a RIGB, but they keep quite this big gastric pouch. And remember, there is no virus. Still, there is no virus. It's just a gastric pouch is longer, and also it's not blue and white, but it's sort of like a bureau of two, right? So they put in the gas GJ bypass, right? Principle is almost the same as the RIGB, which is restricted and non-absorptive, right? It's simple and fast. Yes, it's actually faster than RIGB because RIGB there are two anastomosis. This is only one. And the thing is the access weight loss is only 50 to 85%. The good thing is the learning curve is short and there is an ease of anastomotic suturing. That's why most of the newer surgeons nowadays, they like to do this. What is the disadvantage? It's very notorious to cause refluxes, 10%. Stoma ulcer is less than RIGP, but still, there is still stoma ulcers, right? 3 to 4%. And yes, there is actually studies have been done, has shown that the malnutrition is actually more than the RIGB. And all these malabsorption, usually they don't present then after the surgery. It only present after 18 months, usually, right? And of course, they can cause dumping syndrome as well, all right? And okay, sleep. Sleep is the most popular bariatric surgery worldwide. Okay, according to IFSO 2024, this is still the most popular bariatric, right? This is your Taylor Swift lah. Huh? All right, the principle is this is a restrictive. Initially, we thought this was restrictive, but if you look at the foregut theory, it's actually hormonal because it reduces ghrelin production. 70% of the stomach volume will be taken out, right? Advantage is fast and simple. It's fast and simple, right? You just put in the stapler, pa, 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 pa. That's it, done, right? Yeah lah. Macam senang kan, okay? But when you do, it's difficult, right? Okay. Learning curve is actually very fast, quite fast, faster than other procedures, right? Refluxes actually can be the when sleep gastrectomy first introduced, the problem is the reflux. Most of the patient have a lot of reflux, right? So, but this has been settled because we can fix it with a hiatal hernia repair, right? And the disadvantage is the weight regain, usually after 2 years, right? So because of this is quite promising procedure, and so, and we know the weight regain is a problem. And the one thing is, what you notice is that there is almost no malnutrition in the sleeve gastrectomy, all right? But the one thing is because of the weight regain, so we were thinking of combining a sleeve gastrectomy with other procedures, right? And when you do this, we are not looking at the malabsorptive part, we are not looking at the restrictive part, but rather we are looking at hormonal part. So just now I told you hormonal is foregut and hindgut, right? So sleeve gastrectomy is actually a foregut and hindgut. We haven't settled the satiety, right? So the satiety, you can either do a duodenal switch, you can do a, this is SEDIS, right? You can do a roux and wine, DJB, you can do a loop DJB, you can do a interposition, you can do a PJB, right? There's a lot, right? But I'm not going to tell you all this because all these, most of them are experimental. And I just described a few, maybe two, right, to you guys so that you guys roughly know. And this is the ceiling, okay. This BPD with a duodenal switch. This is the ceiling, right? The most difficult procedure, right? Because namely because you have to transect the duodenum. The the thing is duodenum, if pancreas is your wife, duodenum is your mother-in-law. All right. So you don't want to go and kacau your wife and mother-in-law, right? Okay. Because duodenum is very vascular. It's rich in vasculature. So if you are not careful, you bleed. When it bleed, you cry, right? So the principle is the reduction of the ghrelin from sleep. We increase GLP from the distal ileum and malabsorption from the long BP limb. Advantage is quite promising, 75 to 90% in 12 months. And the remission of the most comorbidities, disadvantage of it, you still have the advantage of malabsorption, malnutrition. The malnutrition here is namely for diarrhea because of a short common channel. And vitamins, there are some vitamins, right? And also protein. And the learning curve is very high because you're in Malaysia. This is actually your Mount Kinabalu, all right? So this is your highest. Can we do said this instead? Said this is you have to do like two anastomosis, but said this is only one. Sorry, something hang. Okay, so you see, said this is only one anastomosis, right? Or say this, we can also say this as a DJB, right? It's a durable bariatric surgery procedure. The principle is the same. We increase the ghrelin, we reduce the ghrelin, we increase the GLP. The common channel can be 250 to 300, right? And the advantage, you can go up to 95% of excess fat loss. Remission is about 95% as well. The disadvantage, the learning curve is very, very high. And the malnutrition is also noted, but it's actually related to the shorter length of the common limb. You can actually revise that if you want to lah. Okay. And one of the new kid in the block, and it's quite a durable bariatric procedure. And this is actually a new procedure that has been revisited because this procedure has been done in 1950s. Right. Even actually it's one of the first procedure that been introduced when the bariatric surgery is being discovered. I mean, be not discovered, being popularized, right? But the thing is, somehow it's lost favor. But now it's being revisited because the principle, if you look at the hormonal point of view, it reduces the ghrelin, it increases GLP, and the common channel, you can go up to 250 or 300, all right? Excess weight loss, you can, same like your SEDIS, right? Up to 95%. This advantage, the learning curve here is actually lower than a SEDIS, all right? And the problem with that is not much study has been done yet for PJB, right? So any other question you can just put in the chat box. If not, I've been like, I mean just talking to myself. Okay. All right. Yeah, yeah.
It's already
Joanna.
9 p.m. already, so we would like to remind you a bit.
Oh, okay, okay.
Yeah,
Okay,
but
okay.
it's very interesting, yes.
Oh, sorry.
Yeah.
Okay. 9 p.m. already. Okay. All right. I won't see my time. Sorry. But the thing is, indication of MBS is the definition you must have less than 5% weight loss after 6 months of non-surgical therapy, which is your GLP-1. You can have your, we call it anti-obesity medication. Okay, you can have BMI more than, if you have no comorbids, BMI more than 37.5 is indicated already. All right. So if you have a metabolic syndrome or you have increased cardiovascular risk, which is a hypertension, diabetes, or hypercholesterolemia, all right, you have a BMI of 32.5, is already indicated for surgery. And if it's less than 32.5 and no comorbids, don't do it. All right. You can only do when you're a guru. All right. You must be under clinical studies. And the clinical issue is dehydration. You can have malnutrition. You can stomach ulcers. You can also have a hiatal hernia and GERD. And weight regain. That is the most important issues around MBS. And also depression. We have depression is higher in post-bariatric patients. Okay, so I would like to tell you about MDT lah. Everything is not MDT. It's not the surgeon alone. You can champion the world, but you need a bariatric surgeon. The most important thing player is actually a case manager, dietitians, your physical coach, and also the paramedics, which your OT nurse, your ward nurse. You need a registry and also a social worker to make it work, right? So the recommended follow-up for dietitian, you are talking about nutrition and diet, physical coach, pre and post-op, you can have the structured fitness exercise. Case manager, your case manager is important because you follow up the case, the expected result and target, the what procedures is done, what complication, and also compliance, right? And psychiatrist or psychologist is also one of the important key player in the team, because all patients need to be screened, all right? And surgeons, of course, surgeons is the technician, okay, with expected result, the target, the procedures, and also the compliance, right? Registry, I want to talk about registry. Definition of a high volume center according to it. So you must have a experienced MDT. Your core case volume must be more than 200 cases per year. And also the complication rate must be lower than the standard. Okay, so this is, I would like to introduce you this IPSO, right? IPSO is an international body. And one thing I would like to highlight on registry. Okay, so Joanna asked me to get some example of clinical cases, just a quick one. So this Mr. AB, he did a sleep gastrectomy and a PJB. We did it in the CMUH. And this is his picture in July, and this is his picture in April. And if you look at the progress, right, this is fat mass, and the muscle mass, the most important thing, if you look at the weight, actually the weight is reducing, right? The BMI is reducing, but with sleep PJB, what happened was the fat mass reduced, but the muscle mass remains about the same. This is what we want. This is one of the success story. All right. If you look at the blood results, he was diabetic. All right. 120 is actually prebiotic. They are pre-diabetic. All right. But this is more than 5.6. Right. It's actually pre-diabetic as well. But now it's already 5.7. And the serum insulin was 20. Right, serum insulin, the normal value is 4. Now it's 4 already. The cholesterol is high and actually low. Actually, you just look at them, just doing a sleep PJB, they can have this one. Oh, you. Okay, so that is the video she gave me. There's a patient. This patient is a female patient, and also she did the sleep PJB from May to February, and you just look at her index, the fat mass. I want you to look at the fat mass. The fat mass has been reducing, but the muscle mass remains about the same. So that's why this is what we need. And she is diabetic, and now she's not diabetic anymore. No medications, right? And also you look at the serum insulin, it's also reduced, and the cholesterol level have been reduced, right? So for this, I would like to, with the grace of the chairman, right, I would like to promote a little bit lah, huh? Okay, Mugis. So if you guys want to see face to face, okay, we can have a chitty chat, right? You can come to Mugis. This is in Penang in July 26 to 27, right? And also Pensa. this year PENSA, that means internet is Asian parental and enteral nutrition society PENSA. You talk more about nutrition in this PENSA. This is also very good. This is 7 to 10. This is actually near you. This is Shangri-La Hotel. All right. So I think I have stopped my presentation, and this is any questions I can entertain. All right.
Yeah, thank you so much, Tengo, for the amazing presentation. We have some questions from our participant to you to answer, but
Okay.
we also like to open the floor to any participant who would like to ask answer to our speaker. Okay, either raise your hand under the react button, or you can type your question in the chat box that we will entertain to you shortly. And can I get Jensen help me to share the question that we have gathered during our sign up. Okay, so the first question I think will be a medical student who
Okay.
what is the specialization pathway to become a bariatric surgeon in Malaysia?
Okay. So, well, this you sure this is a student, not a surgeon. Okay. All right. All right. Okay. Okay. Thanks, Noah, for this. One thing is a specialization pathway to become a bariatric surgeon. The problem with Malaysia, bariatric is very young. We're still in the infancy. So if you want to be a bariatric surgeon, there are two ways currently, the current one, to be legal. Actually, most of us are illegal anyway. So what thing is, you can either, like me, you become a surgeon first. But I mean, the first of all, pass your exam first. Okay. You are students, right? Pass your exam first. Okay. Go through your housemanship 2 years, right? Then go to masters for general surgery, right? Then once you become a surgeon, general surgeon, you can go suspect into upper GI, but it's not upper GI, it's upper GI and bariatric. But this is one way, all right? Or we call it a local pathway, all right? There's another is you become a general surgeon first, right? Then you go to do fellowship. Of course, this is from your out from pharma pocket lah, or your own pocket lah. All right. You can either do a fellowship like me. I do fellowship in Huang's in the Prof Huang in CMUH, right? You can also NTU, UVJ, Taiwan, or you can go to Italy. You can go to America. There are a lot of a fellowship program, right? And there is some newer how to say local pathway, but that has not been it's only still under discussion, area of interest. Everybody has been talking about it, right? I think this one is still in under the discussion, right? I think whatever it is, the most important is the passion, right? The passion to what? The passion to make obese patient to become normal. I think that is more important, right? Okay, but you guys have my LinkedIn, and you guys have my this whatever contact, right? All right, you can always contact me, right? Then we see what we can do. But most important is pass your exam first. Okay, good question, huh? Right.
If you found this video helpful, please like, share, and subscribe. Join the movement to eliminate obesity and reverse metabolic syndrome. Together, we can make a difference. Hit the notification bell so you will never miss an update. Follow us on social media for more tips and support.